Yeah. Okay. Looks like we have 4. Okay. Uh-oh. Let's see. Okay, hello everybody. Welcome back. We're doing pretty good on time. We're within the 5-hour threshold of always being overtime, so we're good. Again, thank you very much for your participation and your attendance. We truly value your presence. But at this time, this is going to be the workshop or the breakout session for community health workers. At this time, can I please have all our presenters go ahead and make your way up onto the stage here? We're going to try to buy some time so we can have more presentation time for you folks. And then again, similar format, I'm gonna introduce the presenters, and then if we could please hold sorry, I'm still getting used to the whole glasses thing. If we can please hold the questions and comments towards the end of all of our presentations. Again, it's always a challenge for participations, presence after lunch. So if we can give yourselves a round of applause for being here, being present. So give yourselves a round of applause. All right, we're going to jump right into this. I'm going to do the first presenter. Mr. Nena Tolenoa is the Executive Director of the Kosrae Community Health Center since its establishment in 2015. Mr. Tolenoa has been providing services in primary care for more than 20 years in different capacities. He leads the development of the Kosrae Non-Communicable Disease Emergency Response Plan, the Kosrae Comprehensive Cancer Control Plan, and Community Health Center Program. He is a member of the Cancer Council of the Pacific Island Primary Care Association, Board of Director, and Vice Chairman of the Kosrae Utilities Authority Board of Directors. Ladies and gentlemen, please welcome Mr. Tolenoa.
All right, good afternoon. He already introduced me. I'm from Kosrae. So if you look up here, some people refer to Kosrae as the island of the sleeping lady because of the mountain up there. It's in the form of a sleeping lady. It is not Photoshop, it's a true feature in our island. Yeah, so some people refer to it as the island of the sleeping lady. But ladies over there are not sleeping. They are doing their job to be active contributor to the development of the island. So don't be mistaken by that name. So I'm just gonna share how we address the need for community health workers in our island. We also refer to them as outreach workers. Oh. Oh. Which one? This one? Sorry, we don't have this in the islands, so. Okay, so every time I come to these big places and introduce myself as I'm from Kosrae, the question is, where is that? What is that? So I think it is important to maybe provide some background demographic on this very small island. I even forgot I need to use my glasses. I'm not that nervous, but I don't know why now. Yeah, so if you look at the map, we're just right there in between Guam and Hawaii. We're in the northern Pacific, easternmost part of the northern Pacific. We're the easternmost state of the Federated States of Micronesia, close to the Marshall Islands. They get paid for the nuclear fallout, but we never get paid for it. Even though we may have been affected by it. Thank you, Marshalls. So down here is in the smaller map, that's the island, four major municipalities, or we call it villages. The population is 6,616 people, 6,000 plus. You almost know everybody. About 62% of the population don't have insurance. Uninsured population. Unemployment rate is around 58%. 98% of the households in Kosrae is below 200% of the federal poverty level. In terms of health expenditure, each household is 300 plus compared to 7,000 in the US. So that just shows what we're dealing with, the disparity that is there. So just to add on to those, in 2012, the governor declared a NCDL emergency and health emergency due to the non-communicable disease problem that we have. So what I have up here is a summary of some of the measures that we're tracking in our non-communicable diseases. We compare to the rates in the US and also in Guam. So when you see where you see the red arrows, those are measures that we are greater than or we're above what is the current measure in Guam or in the US. So those areas are youth current smoking. Adult current smoking is higher than US. Tobacco chewing for youth is both higher than Guam and US. We're at 31%. Adult current tobacco chewing is even higher. Meeting the recommendation of 5 servings of fruits, we're way up higher than Guam and the US. We're at 95% of the population is not meeting that recommendation. So no wonder why we have that problem with the NCD. Adult overweight and obese is even higher than both Guam and the US. Diabetes prevalence is even higher than the US. So this is just show you the situation that is existing in the island. So we've been having that NCDL emergency for almost 5 years now, and it's still not lifted. I'm sharing all this because it really leads up to the importance of transforming the current health delivery system, and also the importance of utilizing community health workers in the island. So like I shared, having been in a NCDL emergency for the last 5 years, It is not business as usual. We have to transform the way that we deliver healthcare in the island. So some of the activities that has lit up or identifies help us how we are to transform or revolutionize the healthcare delivery system, and also identified the importance of community health workers. In 2011, there was a NCD needs assessment that was conducted in the island, thanks to the PCDC, Pacific Chronic Disease Coalition. They sent down Dr. Ichio to conduct the assessment, and part of that assessment is training needs was identified as we need to utilize community health workers if we want to improve and change what is happening in the island. And also we need to utilize a team-based approach if we are to make changes in the current situation in the island. And also the establishment of the Kosrae Community Health Center in 2015 was also in response to this health emergency. So through the establishment of the Community Health Center program, outreaching service was identified as a priority also. It's really changing the way that we provide services. Instead of waiting for people to come and get service, we have to take it to them and where it is closer to them. Because most of the people, when they come, it's already late. It's always late diagnosis. So we cannot continue to stay and wait for them to come in. So that's why outreaching services is very important. And also we identified the Pacific Chronic Care Model, PCCM, as a very important model that we should be integrating in the way that we provide service and address the chronic disease problem in the island. So all of these activities has prioritized community health workers training or services. So if you look at this photo, the lighter part in these, although we are facing all these health problems, we have some very unique features in the island also. The lighter part in the photo is, that's the last strand of Terminalia forest in the world today. The U.S. Forest Service is working with the landowners to preserve that because they say that's the last in the world. So you cannot find it elsewhere. You have to come to Kosrae to find it. I'm just sharing because if we don't do a good job in addressing the NCD crisis, then all these unique features and nice things about the island, nobody will be left to enjoy it. So that's why I want to use this photo in here. That's why we need to transform the healthcare delivery system. So just to share a little bit on when we provide the training for the community health workers, what type of training were provided and all those. So the first training that was provided to the community health workers was visual inspection with acetic acid training, VIA training. We've been using pap smear for cervical cancer for a long time, last 20 years. Coverage rate is always between 10 to 20, never go beyond. Highest we'll get will be maybe close to 30% coverage of eligible women that should be screened for cervical cancer. VIA is a screening method that is most appropriate for us. We don't have on-island cytology, and it doesn't require only nurses to be the one doing the screening. So that's the first area that we train our community health workers on, the VIA screening. It's more appropriate for the island. We have to send all slides to Uams or Hawaii. Each slide costs $25, whether it's negative or positive. We pay $25. Results sometimes don't come back, but when it comes back, the staff never inform the patient of their results. So that's why it's important to have that VIA training. Also, our community health workers, they got trained on the job. So another priority area that we train them on is basic public health. Health models, ecological model, social determinants of health, the difference between prevention or the importance of prevention. So we have to give them the basics also. That's also one priority area that we identified. Also, as part of the Pacific Chronic Care Model integration, we also trained them on motivational interviewing, Pacific way, not just motivational interviewing model that is being used elsewhere. We have to Pacificize it. So we call it motivational interviewing the Pacific way. So that's another area, because self-management and teaching others, encouraging others for lifestyle modification is a huge thing that if we want to make some changes. We also provide training on NCD-specific diseases that are common to the island, like cancer, heart disease, stroke. So all the symbols are up here. That's it. They're drowning in this mangrove channel. That's the idea on this slide. And even Tiberius. So these are just some of the mature areas that we have trained them so far. And also when we provided the training, it's just like, not like the usual training where somebody come out from the outside and conduct a 1 or 2 day workshop. They just come and listen. It's very systematic. Organize it in a way where they even have to undergo examination. They take pre and post stage to ensure that they have learned something. It's certain training area also require a number of hours that they have to put in, because the ultimate goal is we're building up a certification and credentialing system that we hope we can establish in the near future. So those are some of the mature areas that we have trained them. And also another thing that we want to make sure that whoever we bring in from the outside to provide training, it has to be very specific to Kosrae. Data, examples, and all those has to be very specific to Kosrae. So we send out RFP for training, and guess who we find? Guess who responded and come down and trained? The Queen of the Pacific, Nia. So if any question on the specifics of our community health workers training, direct it to her. So that's it. It's storytelling, just letting you guys know that we're trying our best to utilize the community health workers. And the next step is really developing support services for them to continue to develop their capacity, and also that credentialing and certification plan to be put in place so they can be credited for all their efforts, which is going to be helping when they go out to the community to provide the service also. So I've been sharing a lot of photos from my island. Last unique feature that I want to share with you about the island is, if you go around the Micronesian islands, you will notice that each island may have 1 or 2 features. Some don't have mountains, don't have rivers. They may have the beach, but they don't have the mountain. But as you notice in all the photos that I share, we're the only one island that God loves so much that all the different features that you don't find in the islands, you find all of it on the island of Kosrae. So if you're a provider, we're looking for providers. You don't have to go to many islands to see all the nice features of a tropical island. Come to our island. Thank you.
Thank you very much, Mr. Tolanoa. If we can give another round of applause to Mr. Tolanoa. So for all you churchgoers, it seems like God has many children and many favorite islands, so we all share the same story. Okay, our next presenters I have the pleasure of introducing is, Ms. Jones serves as the community health nurse for the Marshall Islands Health Project, helping others navigate healthcare and social resources system in Iowa. For the past year, she has served as the liaison between outpatient clinics and Mercy Medical Center in Dubuque, Iowa. This past May, she completed her doctorate of nursing practice in family medicine and is transitioning to a healthcare provider role. Let's congratulate her on completing that. Next, we have Ms. Ernst is a native of the Republic of Marshall Islands and currently serves as the community health worker at Mercy Medical Center in Dubuque, Iowa. She previously served as a nursing aide for the Sisters of Charity of the Blessed Virgin Mary and is active as a community and church volunteer. Ladies and gentlemen, our next two presenters, please welcome them to the podium.
Where do I go from slide to slide?
Yeah, you can go back. I think what's been easier is doing the up and down arrow.
Up and down. So.
Okay. Is that yours?
Except for it's not up there.
Oh, let me see.
Okay. Oh, these at the bottom.
This one's yours?
Yeah.
Yeah. That one I
Like it's showing right now, but I'm saying it's not up there.
Slideshow. Beginning.
Oh, thank you. You're welcome. I was like, it's here, but not there. All right, thank you. So I'm going to go ahead and get started, and Irene will join me at the end to be able to share a little bit about her experiences working together. So I'm going to be talking about the development of a Micronesian community health worker program within the Midwest. And as the bio stated, we live and work in Dubuque, Iowa. So these are some of the objectives that we'll be covering, hoping that you'll be able to summarize the health and other environmental issues that are impacting those from the Marshall Islands that are living within the United States. And then also that you'll have an increased understanding of the cultural barriers that the Marshallese experience within the United States and how the community health worker program works to help reduce those barriers within our community. And then lastly, that you'll be able to verbalize how we began our community health worker program and the outcomes that we've associated with our program. So we started with a people-centered health system, looking at episodic healthcare management for individuals. So the opportunities when people sought healthcare and were seen by healthcare providers, trying to see how we can do that more efficiently and in a more effective way. Again, looking at population health management. Again, this is a specific population that we're working with and wanting to help with better care coordination for the community. And lastly, really looking at community health and well-being, being able to work with those who are poor, underserved, and looking at the social determinants of health. And ultimately, the research has shown that when you're looking at all of those perspectives, then you're able to provide better health care, give better health, and also have lower costs associated with that. So I know we've spoken about it a lot, and it's been mentioned in many other aspects of our gathering this week, but who are the Marshallese? It's part of the Pacific Islands. It's 70 square miles of land. Population estimate is up there. The U.S. had control of the Marshall Islands from Japan back in 1945, and something that's often mentioned a lot is the U.S. government had tested 67 nuclear bombs between 1946 and 1958, and those ultimately gave the Marshallese many different disease risk factors. They had increased cancers and things like that. They became a self-governing country in 1979, and then also the Marshallese are eligible for immigration under COFA, which is the Compact of Free Association. So what that means is that they follow the same path as anyone else for U.S. citizenship, and they do not have to have a green card either. They come with an I-94. Additionally, their I-94 doesn't have a specific date that they have to leave by, but rather they have the legal status to live and work in the U.S., but they also retain their full Marshall Island citizenship. Ultimately, COFA migrants, Marshallese, that I'm speaking about today, they've been excluded from state and federal benefit programs. So on a federal level, we've not been successful in requesting that, for example, Medicaid and Medicare are opened up to COFA migrants. Each state is able to make their own choices on a state level, and so Washington and Oregon have chosen to allow that for their COFA migrants. Iowa has chosen to allow that instead for COFA migrants who are under 18. But every state does things a little bit differently, which can cause changes in communication and make it difficult for COFA migrants when they move from, say, Washington to another state that doesn't then offer the same benefits that they were receiving within that state. So again, who are the Marshallese? There's about 300 to 600 that live in Dubuque, and the nearest estimate that we can tell is that there's around 1,000 in the state of Iowa, obviously very small related to other pockets of COFA migrants. Again, the largest populations of Marshallese in the U.S. would be in Arkansas and Hawaii. And then when you compare the numbers, so compared to 8.3% of U.S. adults, prevalence estimates of diabetes range from 25 to 50% in Marshallese adults. And that rate is considered to be one of the highest in the world. So what that means is in your typical population, the number of people that would have diabetes is not as high, and it's disproportionately higher in those who are Marshallese. So where did we start with getting things started? What initially began is that at our hospital we have something called a lunch and learn. So it's an opportunity for us to be able to come together as nurses, social workers, really anyone that desires to attend. We have an hour-long session about different things that we want to learn about. And what had been happening is that many nurses and providers said, there seems to be quite a few Marshallese in our town, and we're struggling with how to connect with them culturally. We don't really understand much about them. Can you give us information about that? And so one of the professors in town came to our hospital and was able to present on the culture and background of the Marshallese. And from that, people wanted to be able to do something concrete, to be able to work together with the health disparities that were present. And so that was when we began a coalition of many agencies that came together. So out of that, we also knew that we needed backup for what we were saying and what we wanted to do. So we started a needs assessment that was done in 2015 and 2016. We had a Master's of Public Health graduate student from University of Iowa that came and assisted us in that. We really were looking at the academic publications that had been done in the past, the anecdotal evidence just from talking to community members and organizations, and ultimately that survey that we did, the community-based research, we were able to obtain 82 people that we had surveyed from the Marshallese community, and then 136 organizations within Dubuque. And so listed below, you can see some of the most meaningful data that we had found for us. We were looking at a lot of different questions and asking people, where do you live? Where do you work? What are your concerns? Do you have health insurance? And things like that. So based off of those numbers, that helped us to realize that the vast majority of our COFA migrants didn't have health insurance. Almost 75% did not have health insurance. And then a large percentage of our population, 62%, spoke only Marshallese at home and didn't feel comfortable with speaking English. And then lastly, just kind of looking at housing helped us to gain a greater understanding of the socioeconomic status. So combining all of those facts together helped us to identify that we were going to need to come at with this from a different angle than we had thought we might from the beginning. So as we were doing this, we heard from a lot of people in regards to their concerns, and we also interviewed and spoke with, again, organizations within Dubuque, asking them, do you interact with COFA migrants? How has that experience been for you? Is there anything that you wish you had access to, or anything that would be beneficial in interfacing with COFA migrants? And one quote that we found that was helpful for us later on is that many patients are so ill or chronic disease is so progressed by the time they arrive at the clinic, their care is beyond the capabilities of family practice, yet specialty care is out of reach due to cost. And this came from a provider that we knew from the Federally Qualified Health Center. So those that are familiar with Federally Qualified Health Centers, they're given federal monies in order to help with the health care for rural and underserved peoples. And so that is where people that do not have insurance go, and they're able to do a sliding fee scale that then makes health care hopefully more affordable for them as it's based off of their income. And so what he had expressed was that the patients that he was seeing, because there's no specialty care without insurance, then he had no place to refer his very sick people that he was seeing within the clinic. And then alongside of that, we looked at the social determinants, realizing that language was a barrier, health, the access to insurance, and just having sicker people that were needing to be seen. Looking at housing, financial needs, food, legal and immigration needs, and then lastly, employment. So we decided to start a grassroots effort. So as I'd mentioned, we began the Marshall Islands Health Project, and it was a coalition of many people. There's more than are even listed on the slide, but we were able to have Mercy Medical Center, the hospital in town. There are 2 hospitals in town, but when we pulled the data for our Pacific Islanders, they were primarily being seen by Mercy Hospital, and so we invited the other hospital to be a part of the coalition, and they felt that we would be a better fit. So we worked with the Mercy Medical Center and then Crescent Community Health Center, which is our federally qualified health center, City of Dubuque, the Health Department, and the Human Rights Department. We worked with some of the universities in town. University of Dubuque partnered with us, as well as Clark University. And then we also had the Catholic Sisters of Charity, Sisters of the Blessed Virgin Mary, and then also Sisters of St. Francis. And then we also asked Marshallese community members to be present at the meetings as well for their input and to be able to help guide us in the process. So you can see, not very well, but you can see a picture of some of the people that were attending 2 years ago when the committee was first formed. And then our planning committee eventually became an advisory committee, and we still meet once a month to be able to talk about what struggles we're having and what we can do better and kind of where we're going with our project. So our mission statement is to engage COFA migrants in achieving and maintaining health and well-being by working to remove barriers and to assist in accessing needed resources. So the name we came up with for the Community Health Worker Program, can you explain it?
Pok-Edro in Marshallese.
Can you tell us what it means?
That means the community health worker with all the nurses, community health worker.
And what does this word mean? Explain it.
The words means, Pok-Edro means you get all the responsible for your health, the good health.
Thank you. So I was hired in September of 2016 to begin planning what our program would look like and what we could do. And then we immediately began recruiting for a Marshallese community health worker to begin working with us. And so that was when Irene came and we began to work together, and she began in November of 2016. So the total number of Marshallese impacted so far is 149, which we look at and feel is a good number, considering that there's between 400 to 600 in our community. So right now, as you know, projects always move slow, and they always take longer than we thought that they should. And so many people that we had begun seeing, they're seen in Marshallese time, and they're seen on their own terms. And so in a perfect world, you would get A1Cs every 3 months, and you'd have these magical numbers that would hopefully be improving. In reality, what that looks like is sometimes people are 4, 5, 6 months out before they come back for their 3-month checkup. And so there's people that have joined our project that we are working with. However, they haven't come back for a second A1C and for that second doctor visit. So there's 49 patients that we actively case manage, 22 patients that are inactive. And by inactive, we quantify that as people that came for an appointment or said they desired help with their health and then never followed up with filling prescriptions, or don't want to they don't want to be seen by a doctor anymore, things like that. So they just kind of hang out, and they know that we're there if they change their minds and they're willing to come back and see the doctor or participate in their health care. But otherwise, we've just told them, it's up to them. They get to call the shots. So in those 49 patients that we actively case manage, right now we have 19 total patients with diabetes that have 2 measured A1Cs. And so 12 have decreases in their A1C, 6 have increases in their A1C, and then 1 is unchanged in their A1C. So we're hoping as we continue to collect that data that it helps to show what we can change and what is going well about our program. So what we've tried to do is address those social determinants. So some of the things that we've worked on is to translate the forms at our federally qualified health center. That was really helpful because there's some people that would come in and they weren't able to understand what forms they were filling out. And so, for example, when you're filling out the forms, it's based off of your income and based off the demographics of your household. And people felt that their English was good and then filled the forms out incorrectly, so that they were paying more for their health care than their family actually was comprised of. So when those forms were translated, then they were able to look at the forms and say, oh, I didn't realize the number in household meant mom and dad and kids. I thought number in household was husband and wife. And so being able to clear those things up then meant that the patients we were working with were paying less for their appointments, and it was more affordable for them. Irene has also been awesome at going to provider appointments and being able to translate for the community to be able to understand what the doctor or the diabetic educator or the pharmacist is saying to the patient. Again, under health, we were able to reconnect 25 dismissed patients with Crescent. So to explain the background of that a little bit more, when you are attending a federally qualified health center and you're seeking health care there, if you're leaving bills unpaid or certain other behaviors that you do, then they have the opportunity to dismiss you from care or say that you can't be seen there any longer. And so that had happened to numerous people. And during those initial meetings with the Marshall Islands Health Project, we had decided that a portion of these were most likely from people not understanding or they were receiving notices in English saying, hey, if you don't contact us, we're going to dismiss you because you haven't paid your bill. Or, hey, you haven't been following your treatment plan, and so we need to dismiss you for this unless you contact us. And so we were realizing that those attempts to make contact were being made in a language that wasn't appropriate, and the notices were being sent in a language that wasn't appropriate either. And so from that, Crescent had agreed to take back a number of people that had been dismissed due to those mismanagement things. And so we kind of gave them a head start and took care of their debt that they had so that they'd be able to start with a fresh slate. And then we started out helping them with the cost of their co-pays as long as they were willing to work with our program. So through the program, then we sought to provide disease-specific education, and we often do that in the home. And so when Irene and I go out together, we'll just go to someone's house for a while, and sometimes they don't know if they have diabetes or not. Sometimes they do know that they have diabetes, but we're just asking them, what do they know about diabetes? What questions do they have? And we'll bring models with it, because people really love holding a kidney and talking about what can happen if you have high blood pressure or you have diabetes, or giving them a chance to hold a little model pancreas and helping them to understand that it's kind of like a car that's running out of gas, putting it in terms that they'll be able to understand. We've done a lot of work with pharmacy collaboration. Pharmacy has worked closely with us to email us when patients are due for a refill, or when patients have meds that they aren't picking up, or they'll tell us someone was really confused. And so sometimes we can call them and ask them what was going on or what was wrong, and we're able to help them realize, hey, they were trying to ask the pharmacy for pen needles for their insulin pens, and they didn't know what to ask for. So then we can call and ask them to set that aside for the patient, and then they know when they go back, they're going to get what they needed. And then Irene's been making reminder phone calls in Marshallese, accompanying to appointments, and she's doing about at least 50 reminder phone calls. But in reality, it's also the culture. We like to take those opportunities every time we see people to remind people, hey, next week you've got a doctor's appointment. You know, they call us for something else, and we say, hey, did you remember next Tuesday you got your doctor's appointment? We go to their house, hey, do you care if I write on your calendar, Tuesday at 3 p.m. you have a doctor's appointment? Because the more opportunities that we have to ask them, do you need assistance getting to see the doctor? Do you know when your appointment is? Do you have a plan to get there? That helps them to begin to anticipate and take care of other responsibilities that can get in the way of them being able to attend. And then lastly, being able to work on the navigation of the healthcare system. And that's evidenced in a lot of different ways. I think one way that I can think of, just to share really quick, is that when I first started my job, I was told that COFA kids were ineligible for Medicaid. And so I thought that was how the system worked. And then as I was working on my doctorate, I decided to write a paper on health policy, and I did a lot more digging. And it looked to me like COFA kids were eligible for Medicaid in Iowa. So I called Department of Human Services and spoke with them and asked them. The first woman I spoke to said, no, they are not U.S. citizens. They don't have a green card. They do not get Medicaid. And I said, well, according to the CMS website, it looks like Iowa COFA kids get Medicaid. And she said, let me put you on hold. So then in a couple minutes, she spoke to me again and said, I'm sorry, I just spoke with my supervisor. COFA kids are eligible for Medicaid. And so I think that just illustrates how much navigation of healthcare is needed, because if I had that much of a struggle and I'm a registered nurse that knows the healthcare lingo, knows who to contact, and kind of knows how to navigate that system more, we're really setting up our COFA migrants for failure when they're seeking to access something and then being told no, and they don't know where to go from that no. They just think that they're not eligible then. Additionally, we've done a lot of work with helping to get children on Medicaid. Sometimes Irene will go translate for those appointments. We've been filling med boxes. There's also a big gap in wound care and home health care, just because people don't have insurance, then they're not eligible for that. But since I'm an RN, we've been able to provide those services to our COFA migrants that have needs. And then additionally, we've also been able to help even kind of all of Iowa, because there's a free dental clinic that happens once a year, and we take responsibility for translating. Irene takes responsibility, not me, but Irene takes care of translating the dental screening information, so that every year we can post that and ask people to share it. And so then it gets shared throughout the state of Iowa, so that the COFA migrants that are in Waterloo or Cedar Rapids or other places are seeing it in their own language and wanting to tell their other friends in the area. Again, we've been working on housing as well, just with advocacy for landlords, assistance through the system. We're really trying to anticipate where those needs are before those needs happen. So part of how that works is looking at our families, kind of talking to them about the difficulties they're experiencing financially, and then getting them on wait lists for subsidized housing or those types of things so that they'll have assistance with that. And then lastly, we've also been doing lunch and learns for the community. So we invite people in and we teach them how to make food, and we ask them for what kinds of food they want to make. And then we teach them how to make those food items, and then talk a little bit more about diabetes and high blood pressure. And then lastly, there's some community gardens in the area that COFA migrants have been involved in to be able to grow their own produce to then be able to take home. Again, working on legal and immigration things. A sub-part of our committee has been working on advocacy, looking at asking for Medicaid to be reinstated in Iowa for our COFA migrants. And so there's a part that's been working on being able to speak to our representatives and senators about legislation for that starting in 2018. We've been helping the families to navigate with getting notarized paperwork to renew passports in the Marshall Islands. We've done workshops about immigration issues with the city of Dubuque. And then I think we're slightly running out of time. So transportation grant, the Iowa Department of Transportation was gracious enough to assist us with a grant that would help to pay for bus tickets. And so that's been able to help our community to be able to get to appointments. And then Irene has been working with the community to teach them how to take a bus. The ones that come from larger cities that have had a bus before, they're more comfortable with it, but those that have come more directly they're afraid to take the bus, and they're worried that they're going to say the wrong things or that they're not going to be able to talk to someone. So we make them signs that tell them where they're going and talk them through what it means to take a bus. And then we've worked with the community. Our community is really ready to learn about COFA migrants and how we can work together. And so we've done several events, and yearly the Marshallese have an Independence Day celebration that's hosted by our Multicultural Center in Dubuque. And then our newspaper has been trying to do more feature stories to be able to help spread awareness of the community. And then lastly, we were able to do a facing project. And so that was a really cool opportunity where one of the social work students from Clark University met with COFA migrants, and she paired them up with someone with an English speaker, and then sometimes there was an interpreter there if needed, if the person wasn't comfortable sharing their story in English. But they went back and forth with a story, and the English-speaking person would then write down the whole story for them and then read it back to them until they were expressing what the COFA migrant wanted to express. And then those stories were published in partnership with the newspaper so that we could understand better what struggles they were facing and what they wanted us to know about the community. So there's been challenges. As everyone knows, community collaboration is hard work. There's a lot of cultural differences related to time, just how you work with chronic disease management and communication. We've really tried our best to be able to go through and find ways to work with the community. I think one thing that we've realized is that there's a lot of different ways to do it. So in our COFA migrant community, at least, many people, they always get new cell phone numbers. They don't pay their internet, so the internet goes out. A lot of different things can happen. But almost everybody's on Facebook. And so we can private message a lot of our patients that we're working with. And there's usually a family member that's on Facebook if they're not on it themselves. And they will get back to us and say, hey, I'll call you, or hey, I saw your message, or hey, my kid was playing with my phone. It won't call out anymore. It will just take phone calls. So if you call me, I'll talk to you. And so it's really been helpful for us to learn unconventional methods to communicate with our people. And then Irene had said that she wanted to be able to share from her heart. And so she wanted to talk to you a little bit more about some of the specific work that she's been doing with the Marshallese.
I promise it won't be long. I've seen people falling asleep. Come on, we come a long way from home, not to sleep, but to learn and prevention for those that they're not now sick. Not only the diabetic people, but those that they don't know where they at. So, a very, not long story, but I'll try my best. Last night, my boss has been, she's my boss. So she said, Irene, you're not preparing for tomorrow. And I said, I'm nervous. These are the smart people, and I don't know what word I'm going to say. Just say something. And I told her, I keep telling her, I'm not doing anything. I'm not writing a note. I'm not. So here I am, nothing but nervous. So when I see the representative from Kosrae, I grew up in Ponape, but my father is Kosraean. So I kind of calm. And then I also see all the my people from the Marshall Islands, which they really cheer me up. So now I'm not nervous. I'm not nervous, but you got two eyes, and I got two eyes, but my eyes are beautiful than your eyes. So, so a very short story. I met this family. I've been helping them a lot, which is part of my job. But I pour out on my heart that they have been like a lots of barriers. They don't speak English. They don't know where to go. This, the head of the family, the gentleman, is a very, very sick man. And is out of the job. He lost his job because his condition is not, it's a very, very critical condition that the doctor let him go. So the wife has been working, but she works only 32 hours in 2 weeks, which it's not covered all the bills that they have. So they evicted from their house, which is so sad. And when the principal, I'm talking back, like at the school, the school wants to communicate with them, but it's kind of hard because they don't understand English at all, like language barrier. So that's what I do. Try my best, go to it with them and try to translate. And then yet they're evicted from their house. And then I had to go with them, try to, it's funny because our nurse once you evicted from the house or a rent, there's no way you can get another one, right? So it's a very hard, very, very barrier. So we've been helping him. I even go to the vocational rehab so that they can help this man try to find a job, which is easier because he's been working in a packing factory, which is so hard that he admitted in hospital almost every day. So that's why they cannot have him anymore. So as an employee. So today, this family, now they have their own house. I'm so glad. And their kids been going back and forth. They have a good effort, like they understand what they're doing in school because they just came to the United States. And the wife, when we first met her, she denied any assistance for care. Then one day she ended up admitted in hospital that she came to us and say, I need your help. So this man that I'm talking about, he doesn't really understand his medical or medication. Most of the time, we had to help him, like put the medication, help him with the med box so that he can know what he had to take and what's for the next. And so now this lady of the mom, she got a job, which she's working hard, trying to get her kids and family to be fed and pay for the rent, the rest. There's a lot of source that we try to help them, like to go to the food pantry, find people to help them pay for the bills. There's a lot of work that we do. So I'm almost doing the social worker, as a social worker, and also community health worker. In this area, it's fresh to me because I've never done this kind of work before, but I learned so much. The more I work with these people, the more I learn. And I'm so grateful that I have my nurse here. She's also my boss, that I learned so much. And I wish that this is what we people from the Pacific Islanders, we can do together. Like together, we can make difference. So we're looking forward to those that they don't know that they're sick, but all we do, try to help them so that they can know. They could be like one of the, well, I'm not a PH or doctor, but I'm so glad that I'm here. Thank you for having me today. And thank you, how do I say that? Princess? Thank you so much. Okay. Komoltada. It's not enough, but I know I'm running out of time. So thank you so much for listening.
Thank you very much. Irene, your degree is MPH, my people's helper, okay? You're my people's helper. That's at the MPH. Okay, thank you. Our last speaker, our last presenter is Ms. Moore, grew up in Northwest Arkansas and has a bachelor's degree in psychology and a master's degree in community health promotion from the University of Arkansas. She is also a graduate of the nursing program at Northwest Arkansas Community College. Her areas of interest include healthy aging, chronic disease prevention and management, and health disparities. As an associate director in the Office of Community Health and Research at Uams, Ms. Moore directs efforts to improve access to culturally appropriate health services in Northwest Arkansas region through multiple community-based initiatives. She also manages the day-to-day operations of multiple clinics, including a charitable student-led interprofessional education clinic, as well as a new internal medicine residency clinic. Ladies and gentlemen, let's welcome Ms. Moore.
Thank you, Tana. Thanks for being voluntold by Nia. You've been amazing help. Yakwe and aloha. I am just thrilled to be here. I did not think I would be here, so I'm going to try not to make a fool of myself as Pearl may walk in. Again, my name is Sarah. I have to credit a couple other folks about this on this presentation. Dr. Janelle Hudson, who I don't see here. Oh, there she is. And our two community health workers, Terry and Sammy. I wish they could be here. It's my goal that they will be here next year when I talk more about this program and how far it's come. So I'm just going to give you a real brief overview of the Northwest Arkansas Marshallese population. Dr. Ricklin talked about them earlier and I think gave you all the information you need. The population up here is estimated. I heard and I know that there's a couple publications saying it's about 20,000 Marshallese living in Northwest Arkansas. There are other Pacific Islander groups, Chukis, Gilbertese, Samoans. We actually have a couple Gilbertese ladies that come to our clinic as well. So there are significant health disparities as far as our patient population in terms of accessing care, and not just any care, but quality care. And there's a lot of social barriers to accessing care and following through with treatment plans. Some of the chronic disease and communicable issues that they have are diabetes, hypertension, acute renal failure is very common in our patient population. We see a lot of stroke and coronary artery disease and cancer. We also have some high rates of Hansen's disease and TB, as well as hepatitis B. It's been brought up that our COFA migrants are not eligible for federal benefits, so they are not eligible for Medicaid or Medicare, SNAP benefits, even though they are here legally and working and are paying federal taxes. It does depend on the state they're living in. Arkansas, we have not made that leap yet. That's why we've actually have a lot of our patients I've seen move to California, Oregon, and Washington because they can get health care. And so if they have family there, that becomes a better option if they're struggling with some sort of chronic illness. So that was kind of the problem. That's what we saw or we see in Northwest Arkansas. One of the responses through Uams was an establishment with the North Street Clinic. Dr. Hudson led that charge, and we have been going strong since 2014. It's the North Street Clinic is a student-led interprofessional clinic where pharmacy, medical, nursing, and more recently physical therapy students work together as a team to see patients, and they present to their attending or overseeing faculty members. Everything, they make the recommendations on treatment plan after discussing the case with their faculty, and they review that treatment plan with the patient. So they provide all the care just with some oversight with faculty. It's an invaluable learning opportunity for the students and a way to meet a need in the community. Because prior to the North Street Clinic, the only other option was the only FQHC, federally qualified health center in Northwest Arkansas, which is the community clinic, or the ER, which is still both are the only other options besides North Street Clinic. We realize that we can't serve this population on our own. We cannot do what we do without community health workers. Irma, thank you for what you do. You may not have MD by your name, but you are absolutely necessary. These programs would not exist without you, so thank you. So we have two fully vested, I say fully vested, two dedicated CHWs in the North Street Clinic. When we have a full running clinic, we actually usually have 4 to 5 community health workers, but we have 2 that their sole purpose or their sole job is the North Street Clinic. And for all of our CHWs that work in the clinic, we invest in continuing education for both the community health worker side of things and the interpreter side of things, because they're not just community health workers. We ask our folks to wear multiple hats. They're medical interpreters and they're community health workers. And so we've had medical interpreter training we've made available. We're working on setting up a medical terminology course for them. We have any regular community health worker training through the Arkansas Community Health Worker Association, or ARCHWA, we try to make available to them. Anything through UAMS, research related, any kind of extra training we can give them or make available to them, we do. So currently, we have the North Street Clinic, which is the IPE or student-led clinic. Start as of last July. We also have an internal medicine residency program housed in the same spot, so that's why there's one picture. It's served, when we initially started the North Street Clinic, We had overflow faculty clinics. So when the student-led clinic couldn't see patients because they're only there half a day once a week, we would have faculty members see patients. But faculty stay very busy, and once we were able to start the internal medicine residency program, they serve kind of as overflow. We have now seen over, I have to remember my count, 350 patients in the free clinic. Some of those have since, I say, graduated, moved on to the internal medicine clinic specifically because they've become insured. And so the free clinic is usually reserved just for uninsured patients. And with the establishment of both of these clinics, we've seen this increased access. We have more providers. We're now at 16 internal medicine residents. The medications are covered through a program for the North Street Clinic patients. They can get their medications for $2 a month or $5 for a 3-month supply. Provided education, and they get that culturally appropriate care because we try to incorporate our community health workers into the team. It's not just, I'm always reminding the residents and the students, they're not just here to interpret for you. If you're not sure about something, if you think something isn't going over well with your patient, you can talk to the community health worker. They love to tell you what they think is going on or what they know is going on, because sometimes the patient has told them, and we just don't know. So Dr. Hudson did a chart review earlier in the year, and it showed that basically she pulled all the records, and our patients they're coming in with these very high A1Cs, they're getting better, and then they're just plateauing or they're going back up. So we're seeing this immediate or short-term improvement, but then it just peters off or goes back up. So we started talking about some maybe potential solutions. So one of the things that we talked about was we have these community health workers, and they're predominantly operating out of the clinic, but why don't we send them out and have them go into homes and do some follow-up with some of maybe our more high-need, high-risk patients. We let our community health workers identify 10 patients each and say, who have we been seeing for over a year that just continues to struggle to make these changes and to get better. And it ended up becoming more than 10 patients each, because then it was this patient and her husband, and this patient and his brother. So overall, we started out with 23 patients they're enrolled in the North Street Clinic. They've been with the North Street Clinic, and they're struggling to make those changes. So preliminary results. Let me give you a little background. This started June 1st. So this is the very beginning of a program. This is my first dive into any of the numbers since we started, because I'm just the initial idea was this is going to be very organic, and we're going to let the community health workers drive this and the patients drive this. So I'm very excited to see numbers. It also gives me an idea of what we need to be doing next to make this even better. So we did have, I'll throw out this first. We had 23 participants originally, but 9 ended up being excluded for some unmet criteria. They had no appointment in the last 6 months. The CHW was never able to contact them. They maybe were no longer a patient with the North Street Clinic. When Dr. Ricklin came, we saw a lot of folks go to community clinic, which I understand completely. So I'm very glad he's here. And then, so we lost 9 kind of off the bat. And the remaining 14 participants, we had 7 of them that we saw a decline in their A1C, so it's 50% decline. That's a good thing. But we also had 4 of them, which is almost 40%, had an increase in their A1C, so going the opposite direction. 2 of them have pending A1C, so they're actually due for an appointment this month, and we'll see what their next one is. And 1 had no change. So some of the things our CHWs were doing in the homes that I said if we can't get them into the clinic, because, it wasn't just a matter of their A1Cs aren't getting better, it's they're running out of their medicines. We're not finding out about it until they come in for their 3-month follow-up, and by that time their A1C is it's shot for that 3-month period. They haven't been checking their blood sugar, so they have no idea what's going on with the numbers. They couldn't make their last 2 appointments, so it's actually been 8 months since we see this. We saw a lot of different things that could have been having an effect on their A1Cs and not getting better, because maybe we weren't just having enough hands-on intervention with them, so we wanted to send our CHWs out to them. So they were checking blood sugars at home, out of the blood sugar logs. If the patient hadn't been checking, they would at least have them check while they were there. All of our community health workers have been through the deep diabetes education empowerment training, and so they were providing one-on-one diabetes education when appropriate. They're also assisting patients with accessing community resources. And Irma, you brought up that it's almost like being a social worker. It is, it's a full-time job. And even with this more intensive CHW program, what we saw that we were continuing to see these treatment adherence issues in providers' notes, in the CHW reports. If the whole idea was to get patients to continue or to be more adherent to treatment, which is to monitor their blood sugars, to take their medicines, to come to their doctor's appointments, and they're still missing doctor's appointments, and they're still skipping or running out of medications, and they're still not checking their blood sugars. What's going on that's we're not seeing that needle move? So these are a couple theories I have. I will be testing these out in the next 6 months, 8 months. Both of our community health workers, while they are dedicated to the clinic, are part-time. And I just don't know that there's enough capacity, because their first priority is to be present for clinic. They are there for interpreting and serving as a CHW while they're serving as an interpreter as well. They are a resource both for the patients and for the providers. So if we have clinic, that's where they're at rather than out in the homes. And Irma brought up, I'm going to keep bringing up the whole idea behind social work and the resources. And we know that people aren't going to be healthy if they are stressed because they're worried about losing their job or being evicted or the lights being turned off. So we have to address those social determinants, and we have to make sure those needs are being met first before we say, are you checking your blood sugars? Why didn't you go to the doctor's office? Well, if your car broke down and you're now sharing a car with 8 people versus 3, it becomes that much more of a barrier. Ideally, we would have a social worker in the clinic. I'm dreaming big and hoping that maybe we can actually hire a social worker. Dr. Hudson's back there. Yes, we would love to have one. But our next best option is to partner with the University of Arkansas. They have a social work intern program. We had one last semester. This semester didn't work out. The 2 candidates they sent were great, but they just weren't a good fit for us. And so I had a meeting with their director of internships, and just before I came to Hawaii, she actually lived here for a while, so gave me some really good ideas of where to go and what to do. But I told her what we're really looking for and what we need, and so we're hoping if we can't at least hire a full-time social worker, we can get a master's level student who can help run this program and help with the social services side of things. My background is nursing, so I can talk all day about what you need to do to change your A1C and lower your risk for heart disease. And I'm not well trained and well versed in the social services. I know that these needs have to be met, but let's get someone in there that can do that and can be a resource for our community health workers. I'm also this is also a little self-serving too, because I'm hoping that in this room full of experts, I will get some ideas of some other things I may try to improve our numbers even more. So our next steps is We're going to increase CHW time. That's a definite. Starting actually October 1st, one of our CHWs is officially full-time and will remain full-time. We also have a third CHW that isn't necessarily dedicated to the clinic, but he has really shown a lot of initiative and drive. So my plan is to start bringing him into this program as well and see if we can increase our capacity by increasing our hours. From the CHWs, we have these resources, let's make use of them. My goal is I know I'll have a social work intern. I hope that we will have a social worker for the clinic. And one of the other things that I had talked to Sammy and Terry about before I came was, are we meeting enough? Do you guys feel like you have enough direction? Because initially we were meeting once a week. Once the program got going, we're down to about once a month. And they both said, I'd like to go back to a week. So that's one thing I plan on doing to try to be able to help them problem solve any of the issues that they may be running into that they don't know how to navigate. So any other suggestions would be greatly appreciated. And that is my contact info. If anyone, you can always talk to me here, or you can always email me or call me. So thank you so much for letting me speak today. I'm extremely honored. Thank you.
Thank you again. A round of applause to all of our presenters. And then if we could have our mics ready to go, if we could have the mics, actually, if you don't mind being up here in the front, it'd be easier to kind of spot our Q&A session here. So this is an opportunity definitely for our audience here to ask the questions. Again, raise your hands nice and high. There is no wrong question. There is no silly question. So I would encourage everybody to ask your question.
My question is for Nena. I'm Bernice Mashashik. My last name is Kosrae, but I'm from Pohnpei. I work at Kukua Kalihi Valley here in Honolulu at Kalihi. And I'm not sure if you're familiar, but the umbrella organization is a medical center like yours, or a wellness center is what we like to call it. But I specifically work for our food program called Roots. And I'm super excited with what you all are doing. So I was wondering if there were any efforts in establishing a food program, just because we've had really great results with, really zoning in on cultural and ancestral foods, especially with our Kofa community in Kalihi. And I also want to reference the work of Dr. Lois Engelberger in Pohnpei and the IFC, and how it was a vitamin A deficiency issue in Pohnpei, but I can't help but think if you link the medical center model with something as successful as IFC and you frame it around NCDs, you could really see something great. So I was wondering if you were thinking about incorporating a food program into...
Okay, thank you. As a matter of fact, we were scheduled to have a visit to KKV, especially for the LD Cafe, because we have already put it as part of our strategic planning to replicate the model at KKV into our community health center program, not only for nutritional improvement purposes, but also as a source of revenue that we put aside. We know the grants will not be there forever. Our island is blessed with a lot of food. Breadfruits are dropping off. People are not eating it. Bananas are rotten on the plant. In the continental U.S., you have to spend a lot of money to eat fresh and organic. In the islands, it's right there, but our people prefer the unhealthy options. Whenever the ship is late to come in and there is no rice, it's like an emergency out in the islands. Yet the banana and the taro and all those are. So we're considering that. Actually, we were supposed to be having a visit, but unfortunately at the last minute, my board members was not able to make it. I'm going to reschedule the visit so we can have Christmas shopping, so we'll do it during December.
Okay, I'll be waiting for you.
Actually, we'll go here and then we'll go to Ben. I think Ben, but we'll go here next. Go ahead.
Aloha, I'm Gerarda Kaka. I'm a physician administrator here at Queens, but more importantly, I'm a friend of Joanne Sark and Neil. Just a thought. First of all, I want to thank the states of Iowa and Arkansas for taking care of the people of the Marshall Islands and the other people of the Pacific. So as you were sharing, I just had a thought, and it's maybe medium, long-term plan, maybe 15, 20 years. There is something about a Marshallese speaking to a Marshallese. Is it something for the CHWs to identify bright students who might have talent and abilities, and maybe scholarship, or encourage them to go into such a health field as CHW's nursing, med school, with the expectation that they'll come back to serve? Because then, when you get a Marshallese or a Hawaiian talking to a Hawaiian, you cut through a lot of the BS and you get right to the root of things, don't you? And so, again, just a thought. Look for young people who maybe can nurture for that kind of work in the future. Mahalo.
I would address that in saying that the third community health worker that has expressed a lot of interest in doing more, he's a young man who's very interested in politics, and I'm trying to convert him to med school. Every day I see him.
Hi, Ben Devanzo with the Asian Pacific Islander American Health Forum. I'm interested in your viewpoints on efforts to kind of more institutionalize community health workers going on in different jurisdictions, both to have perhaps insurers reimburse more for community health workers. For COFA, Medicaid, that's obviously an issue, but perhaps for private insurance, as well as to have certification and professional training for community health workers, which has pretty large upsides and downsides, or if you think those sort of efforts take away from the whole essence of community health workers coming from communities.
I mean, personally, with my very limited experience from this past year, thanks. I think I'd have to say that for at least the COFA migrants that we work with, the Marshallese, the more institutionalized it becomes, the less we're able to reach people, because we've really had to advocate for where we say that something needs to be compromised because it's just not acceptable culturally, or it just doesn't work for our community. And so we've really tried to keep things as our community health worker able to go out and do what needs to be done within reason, rather than having to go through politics and red tape, because really for the Marshallese community, this is our community health worker, Irene. She's taken on this role, and it's become a part of her life, so that she walks down the street and one of the Marshallese in a car pulls over and says, hey, I have a question for you. Or she's at church and somebody's saying, hey, can you show me how to check my blood sugar? I mean, obviously she's not being paid in that moment. That's not a part of that. And you can lose that tasking, that my responsibility, when things become more institutionalized.
That I would add on that that is a concern addressed by the Arkansas Community Health Worker Association. I sit on their board and technically Region 5 chair, which is the Northwest Arkansas area. And there is a push to get certification, because we know that with certification, oftentimes we start seeing the reimbursement. And with reimbursement, we have more options in terms of what we can do with the program, what we can pay our community health workers. But the fear is that when you institutionalize it, when you put these restrictions on who can be part of this program and be considered a community health worker, you're going to end up locking people out. So I think it's a fine line because you don't want to lose the value and lose the effectiveness of the community health worker. At the same time, having that extra funding makes a big difference because you can do a lot more with your program. And I will say this, so this program started through a CDC REACH grant, and my job was to liaison with the healthcare providers in the area, with the hospitals and clinics, to promote the use of community health workers. They don't want to hire a non-certified anybody. They say, well, that's a great, they think about it, well, that's a great idea, but I don't know who this person is, and why would they be part of the care? Even though we know CHWs work and are effective, Arkansas is a little bit slow on the uptake. But also, there's the idea of, well, who's going to pay for this? Even though we know community health workers pay for themselves, there's just the beginning of getting a program up and running. And so that was the conversation I had for the first year of working on this REACH grant. It has now become more acceptable. You work with Mercy, and Mercy has done an amazing job in the last year. I've seen they've got so many community outreach workers, and not just in Northwest Arkansas, Iowa, Missouri. So they've really adopted this idea and run with it. The other two main hospital systems in the area are still struggling with this idea of let's reach these populations that we haven't been able to reach by working with the population. So lots of work left to do.
And we'll go with our last question right here in the middle.
Thank you. I just want to echo what the gentleman said over here about the Midwest, what you guys are doing over there to the minorities, especially the Marshallese. I'm born and raised in Ebi, which is in the Marshall Islands, and really appreciate what you guys are doing, not just to the Marshallese, but the islanders who are there, all the way there, out there. Thank you. But my question is, neighbor, Nena, besides your data of disparities, I can see desperate there. You are selling your islands to any providers that are there, I guess, to the health center. My question is, we might have the same issue. I just wanted to ask why.
Oh, advertising for providers? Not any. I think not any providers. Providers that would accept the low salary that we're offering in the islands. Yeah, but really the fact is we have a very limited pool of local physicians and nurses. Some have moved out to the other states in the FSM, but that's really what's behind. Initially, we felt it when we established the community health center that the best thing is to just utilize local physicians that really understand the patient. So there will be no barriers in language and understanding of culture, but I think we have reached that stage where we may need to reach outside, but the challenge is we have to put something that is more attractive than that level of salary. So that's why I'm adding all those value added of the uniqueness of the island and all those to lure those providers out there.
Thank you, Nena. I know that, and we're having that issue also in the Marshalls, and I just wanted you and me to say that right now, because I know there are providers out there.
Actually, we'll go with one more right here in the aisle. This is our last one. And again, they will be available throughout the next few days, yeah?
I'm Michael Levin. I've been doing surveys of Micronesian migrants since 1992, first under Interior and then FSM funded the last one themselves. Marshall's hasn't had a similar survey since 2003. First a little bit, Interior funded 2 units, one in Guam and one here, a few years ago for Micronesians, FAS, and to come in, the COFA people to come in and talk. And the main problem, especially on Guam, was that only the people who didn't need it were the ones coming in. So I want to applaud all of you for, especially the people working with Marshallese in the U.S., for reaching out to everyone. We now have in Hawaii, We Are Oceania, which is a fantastic group and is doing exactly what has to be done, which is to find all COFA people and approach them and bring them in. And this is an incredible organization. My question is sort of a comment as well as a question, which is, the 2 ones from Iowa and Arkansas are parallel in what you're doing. And I'm worrying about this constant reinvention of the wheel. You can certainly learn from each other, and this is what you can come together once a year here to do this. But in fact, there should be a coordinating agency. That agency should be probably in the embassy in Washington and then in the consulates here and elsewhere. And I'm just wondering about your thoughts about whether there's some other means. I guess it could be Facebook, it could be other methods where you can actually not have to wait once a year to have this exchange. Thank you.
NIA is our connection to Iowa. Put this on NIA. Yeah, actually, Kayla and I have actually met before. She recognized me. I knew I recognized her face, but we've also exchanged on Facebook. So there's been some exchange prior to this. But you're right. That's the whole idea of doing community-based work, is being able to involve the community. And while they are in Iowa, it's the same population, and you're obviously seeing the same issues. So it's a very good point that you make.
Okay, and again, thank you again for attending this Community Health Workers panel. It's a true passion of mine. So I was very, earlier, I don't know if you heard, I was fired, but then I guess I was rehired. But I'm glad that I ended up being on this panel because it's a passion of mine. To me, I don't know if folks know I'm a PK, a preacher's kid. And to me, as Pacific Islanders, when we're born, I truly believe that we're born as community health workers. So it's definitely within our path, it's in our DNA. And then I just want to recognize too, just having Hardy in the room earlier, I always think of paddling. And if folks know who paddle and those who don't know paddling, each seat has a responsibility. And I think that we have a good display here of academia, medical institutions, community, elders. But the theme is community health workers. And for those of you who know paddling, seats 3 and 4 is the engine room. And I truly believe that the community health workers are our engine in the work that we do today. So I want to do something a little modified thank you. Instead of just the general clapping, I'm going to do a little kind of variety of interactive of our audience in appreciation to our presenters here. So what I'm going to have you do is stand up. Since this helps towards food coma, And I know some of us must have had that heavy food coma. So a little cue from the preacher's kid is, if you're ever caught in that situation, when someone taps you on the shoulder, just say, "Amen." Okay, that'll help you get out of it. But for this appreciation exercise, interactive, to show our appreciation to the panel, when I lift my left hand, I want you to clap. Okay. When I lower it, you stop. When I lift my right hand, I want you to stomp. Okay. So let's do a little practice. Okay, I know some of you are more heavy feet than that, Okay. All right. Okay, now this time I want you to look around and look at each other, because there's just some beautiful and handsome faces out there. So go ahead and look at each other, spare some of that energy, and then look back here. Ready? All right, now let's show it with some emphasis to our panelists here. Okay, ready? Gotta get ready. Okay, and then all together, let's welcome and thank you, our presenters. Thank you very much, and we're going to be going into break, Nia. We're going to be going to break, and then we'll have a further discussion. Actually, I can just talk about the World Cafe. After the break, we're going to have the World Cafe if you're interested in the diabetes prevention. That's going to be in the back part of this auditorium. For the pathway to health careers, that's going to be towards the front of the auditorium here. For Veterans Health, that's going to be in room 202 upstairs. And for Pacific Islander Health, that's in room 200. Okay? Neil? Thank you, everybody. I'm back on the unemployment list.